Today's webinar hosted by the Division of Health Systems and Public Health. My name is Dr. Juliet Nyasuru from the division. Let me introduce our presenter today. The topic is rolling the wheels of collaboration, tobacco control policy development, and alcohol policy implementation in Zambia. Our today's presenter is Dr. Adam Silumbwe. He'll be presenting part of his PhD work. And Adam right now is from the University of Zambia, but physically here in Cape Town. As I'm talking, we're in the same office. He's around in Cape Town working on some collaboration visit with University of Cape Town, University of Western Cape. And Adam and some colleagues from University of Zambia, we are on a same project, an EU-funded research project, which is looking at implementation science for NCDs. And that's how we met. We're together in Lusaka some 3 weeks ago. They hosted us, and now he's in Cape Town. So today he'll be presenting some of his work from his PhD, and you are most welcome. So because of the echoing, since we are in the same room, what will happen is that when you'll be presenting, if you have got any questions or comments, you can put in the chat box. And if there is anything, it will be Chanel to speak up until at the end when I'll be taking those questions. Because if I speak whilst he's presenting, then it means that there'll be a lot of echoing. So thank you so much. Welcome. Let me now hand over to Adam. I think Adam, you can move. Okay. Thanks.
Adam, just remember to unmute.
Yeah.
Hello, can you hear me?
Yes, thanks, Adam.
Perfect. Great, thank you. Okay. Perfect. Great. Let me just okay. Thank you, Dr. Yasulu, for the introduction. I'll start. My name is Adam Silumbwe. I'm from the University of Zambia in the Department of Health Policy and Management at the School of Public Health. And up to about the 29th of April, yeah, I was a PhD student at Umeå University in Sweden. And I'll be sharing with you work from my PhD, as Dr. Nyasulu mentioned. And on the bottom right, as you can see, are the team that supervised my work, headed by Clara, Miguel, Joseph, and Charles. A little bit also about me, that in the Department of Health Policy and Management, I'm basically a health policy and systems researcher, and I'm also a lecturer in that department at the University of Zambia. The title of my presentation today is Rolling the Wheels of Collaboration, Tobacco Control Policy Development and Alcohol Policy Implementation in Zambia. And this is my presentation outline. I will take you through the context of tobacco and alcohol control in Zambia. And then I'll share with you the general objective of my work, as well as the theoretical and conceptual underpinning. And then I will get into the 3 main sub-studies that constituted my work. And then I'll share the results and then provide my recommendations. The background. Tobacco and alcohol are the main drivers of premature mortality and are common risk factors across major non-communicable diseases. Together, they account for 3 to 8 million deaths and between 131 to 200 million disability-adjusted life years are lost annually. In Zambia, tobacco kills more than 7,000 people, leading to losses of more than 100,000 disability-adjusted life years every year. Majority of Zambians, about 64%, are lifetime abstainers, a common trend as in other sub-Saharan African countries. Yet among those that drink, more than 60%, particularly men, are heavy episodic drinkers. The tobacco control context in Zambia is such that we have about 20,000 tobacco farmers. We do have a statutory instrument that bans smoking in public places. Another statutory instrument tries to regulate labeling as well as commercial advertising of tobacco. We have an excise tax of about 37% on cigarettes. However, this is considered lower than the threshold recommended by the World Health Organization of about 70%. The alcohol control context in Zambia is such that we have the Liquor Licensing Act of 2011, which is essentially a law that regulates possession and sale of intoxicating liquors. Alcoholic beverages are sold without restrictions in Zambia generally, even if the Public Health Act does set the age of about 18 years. We have no legally binding regulations on advertising and marketing of alcohol in Zambia. So what has been Zambia's policy response to the problem of tobacco and alcohol? In 2008, Zambia signed the World Health Organization Framework Convention on Tobacco Control, which is essentially a global policy framework that galvanizes countries to respond strategically against the tobacco pandemic. In 2009, Zambia began to formulate the first comprehensive tobacco control policy, and this policy would include both demand and supply side measures. In the same year as well, Zambia began to work on the alcohol policy. And as you can see at the bottom are key actors that have been involved since then in this process, including the Ministry of Health, local government, finance, education, agriculture, and some non-governmental institutions there. In 2010, the first draft of the Comprehensive Tobacco Control Policy was completed. It was submitted to the Cabinet of Ministers. Unfortunately, it was rejected by the Cabinet of Ministers. They cited that there had been insufficient consultation and lack of consensus amongst the different stakeholders. In 2018, we fortunately completed and the Cabinet of Ministers approved the alcohol policy. And in this year, we began to implement the alcohol policy. In 2020, the second draft of the tobacco control policy was completed. Again, it was rejected by Cabinet, citing insufficient consultation and lack of consensus amongst the different stakeholders. In 2022, the third draft of the Comprehensive Tobacco Control Policy was completed again. By 2023, when I was winding up on my thesis, we had changed government, and fortunately, the draft tobacco control policy was approved by the new Cabinet of Ministers. But as I mentioned, as of today, this draft tobacco control policy has not yet been taken to Parliament for debate and approval. So what was the rationale of my work? More than 25% of national mortality in Zambia is largely attributed to non-communicable diseases related causes. And we know that a lot of this is driven by common risk factors such as tobacco and alcohol. And as you could see from my previous slides, for over a decade of collaborative efforts to formulate a comprehensive tobacco policy, but yet the progress has been slow. The alcohol policy in itself does set a lot of ambitious targets. However, we do know little about the collaborative dynamics that shape its implementation. I believed that with my work, unpacking collaborative dynamics would provide important evidence to enhance tobacco control policy development, as well as alcohol policy implementation in Zambia. The general objective of my thesis was to contribute to better understanding of the system's context and the collaborative dynamics during the development of the tobacco control policy and implementation of the alcohol policy in Zambia. So my work had three main specific objectives, and I must mention that each of these three specific objectives culminated in a sub-study. So essentially, there were three sub-studies. I will not belabor the slides on the objectives now, because I'll be talking about them as I present on each of the three sub-studies. The theoretical and conceptual underpinning of my work, in this study, essentially, I use a collaborative governance to a collaborative governance theory, or rather a collaborative governance lens to policy analysis. And essentially this theory tries to explain how actors from different sectors engage in consensus-oriented decision-making to address complex public policy issues. It establishes really how and when the actor dynamics can lead to either success or failure of any collaborative undertaking. To do this, I use the Integrative Framework for Collaborative Governance by Emerson. So this is a framework that highlights crucially and interrelated factors that are able to explain, the success or failure of any collaborative undertaking. So you can see the dimensions of this framework include the system's context, which is the dark box that is outside there. And then within that dark box is the collaborative governance regime presented as a dotted line, and its collaborative dynamics inside there, as you can see. And these collaborative dynamics interact, leading to actions and adaptations that affect the system's context. I must mention that the system's context is essentially the policy and legal environment within which collaboration takes place. The collaborative governance regime, I focus more on the collaborative dynamics inside. The collaborative dynamics there, as you can see, are represented as rolling wheels, because these are the dynamics that give life to collaboration within the policy process. They are initiated there by principled engagement, as you can see, leading to shared motivation, and as they spin, they lead to actions that impact the system's context. I situate my studies within the different layers of this framework. Sub-study number 1, I'll be talking about it, but it sits within the system's context, understanding the policy, legal, and socioeconomic environment that shapes collaboration in tobacco and alcohol policy in Zambia. And then sub-study number 2 focuses on these collaborative dynamics of principled engagement and shared motivation. Sub-study number 3 focuses on the capacity for joint action. I'll be explaining more on each of these concepts as I touch on the sub-studies. So please stay with me on this. So we get into the sub-studies themselves. Sub-study number 1, the objective was to ascertain the magnitude of tobacco smoking and harmful alcohol consumption problem using a nationally representative sample in Zambia. This was a cross-sectional study based on the World Health Organization State Survey of 2017. It's a representative sample of 4,302 individuals, and these are adults of the ages 18 to 69 years. On the left-hand side, you can see this work, this sub-study culminated in the publication of my paper 1. So the paper 1 is published there. As you can see, sociodemographic factors associated with daily tobacco smoking and binge drinking among Zambians. Evidence from the 2017 state survey. I must also mention that in sub-study 1, or in paper 1, we had two main outcomes of interest. That is daily tobacco smoking. And our question, or rather variable of interest, was, do you smoke any tobacco products daily? That includes shisha. Or do you use any tobacco products daily? That includes shisha or any other forms of use of tobacco, including cigarettes. Binge drinking, the outcome of interest there was the question that related to how many times did you have 6 or more standard drinks? And so we dichotomized it into those that said yes and those that said never. And so the findings there, the adjusted prevalence ratio of daily tobacco smoking was 14 times higher in men compared to women. It was 2.3 times higher among those not educated compared to tertiary, to those with some tertiary or secondary education. The adjusted prevalence ratios for binge drinking were 3.67 times higher in men, again, compared to women. We found lower adjusted prevalence ratios among rural residents compared to urban residents when it came to binge drinking. We move to sub-study number 2. The objective of this sub-study was to explore and explain the role of principled engagement and shared motivation in the delayed development of a comprehensive tobacco control policy. And this was an exploratory qualitative case study design constituting 27 key informant interviews, and I used deductive and inductive thematic analysis. As you can see on the right-hand side, I published my paper 2 and paper 3. The paper 2 was the role of principled engagement in public policy making, the case of Zambia's prolonged efforts to develop a comprehensive tobacco control policy. Then the third paper from sub-study 2 was collaborative dynamics and shared motivation, exploring tobacco control policy development in Zambia. As I mentioned when I was talking about the framework, that principled engagement is one of the key collaborative dynamics. It is essentially related with the process of bringing together the different stakeholders in the policy process. And this particular collaborative dynamic focuses on who is invited, how is the participation, how is the communication and representation. And so before I get into the actual dynamics shaping principled engagement, I would like also to appreciate the context within which collaboration in tobacco control policy takes place. So what we find there is that there is an unfavorable legal context, which is that when it comes to addressing the supply of tobacco in the country, there are sector policies that obstruct, or rather, are encouraging tobacco production. And so that, restricts efforts to regulate tobacco supply. The adverse socioeconomic context really refers to the challenge that the country faces of pursuing economic development efforts, but also having to regulate public health needs of the country. And so how does the country, balance those two? And so here, for instance, are some of the quotes from the participants. There are 2 quotes there. I will be reading one of them. I'll read the second quote there from an official from the Ministry of Finance. The Treasury needs money, or the little money plays an important role in financing development programs. When you remove the contribution of the tobacco industry, that is something very significant on the budget. We move to the actual dynamics that shaped principled engagement. We find that there's inadequate planning of meetings and there are frequent changes in tobacco focal point persons. So what you find is that in this policy process, one person attends today, another person attends tomorrow, and this affects continuity in the tobacco control policy process. There's lack of active and meaningful participation, which is that some of the sector representatives in the policy process do not exactly see themselves as tobacco control leaders in their respective sectors, and they have the responsibility, to advocate for tobacco control in their respective sectors. And so that affects participation there. And then also, there are some sectors that felt like, they were not exactly playing a key role in this policy process, despite the fact that, they should be doing that by virtue that, some of the tobacco control laws reside with them. We also note communication challenges amongst the stakeholders. Communication around sharing of information on tobacco does not happen as much, unless perhaps when they are about to have meetings. So all these dynamics really affect principled engagement. So here are some quotes from the participants there. I will read the first quote from an official from the Ministry of Local Government and Rural Development. During the early stages of policy formulation, the local government was left out. I remember I had a chat with someone from the organizing committee. I had to say, now you're leaving out the people who enforce there, really referring to the challenge of inclusion and participation in the policy process. We move to the second collaborative dynamic, which is shared motivation. So shared motivation really kicks into effect after the principled engagement has brought together the different sectors. Shared motivation refers to the relational aspects that are born out of, the policy process. And so it is, according to the framework, really typified by 4 key elements, and that is trust, mutual understanding, commitment, and legitimacy. So here are some of the findings, particularly with respect to trust. So trust in the tobacco control policy process is affected by concerns about associated loyalties, which is that people from the economic sector feel that the people in the health sector are propagating this policy because they are after funding from the international partners, whilst those people from the health sector feel that the people from the production or the economic sector are against the tobacco control policy because they are supported by the tobacco industry. There's also a general fear of a tobacco ban, which is that a comprehensive tobacco control policy might turn out to disseminate, to annihilate an entire industry of 20,000 tobacco farmers that I mentioned earlier on. So that fear is really affecting trust in these sectors. Mutual understanding is affected, and essentially mutual understanding is referring to, being able to respect other people's views despite not, agreeing with their take on some of these issues. But this is affected by the lack of evidence on how big a problem tobacco is in the country. I think there are few studies that generally quantify the different dimensions of tobacco control, of the tobacco burden in Zambia. So this affects, understanding amongst the stakeholders. Limited information sharing on, tobacco and its harms in the country. Again, this also does affect mutual understanding, which is that now, these stakeholders question, why do we need this policy? So the limited sharing of information affects understanding there. So I'll refer to some of the quotes here from the participants here. I'll go to the second quote, which says, the Ministry of Health provides alarming data that seem not to align with the realities on the ground. The other ministries argue that this is not true because it is not in the government statistics department, which is the arm doing research on behalf of government. Essentially, this quote comes from a representative from the Tobacco Board of Zambia, and you can see how this participant, referring really to the contestation around the evidence of how big a problem tobacco is in the country. We move to the second component of shared motivation, which is internal legitimacy. Internal legitimacy really refers to how the participants felt, the tobacco, how credible the tobacco process is, but also how credible the content, is. And so this internal legitimacy is affected by these dynamics. Firstly, the sector representatives lack authority to make critical decisions. So these are mostly junior officers from the sectors. And so they can't do much about tobacco control in their sectors, and that affects the legitimacy of the process. There's also the perceived lack of contextualization of the proposed policy content, which is that some stakeholders feel that we are just reproducing the Framework Convention on Tobacco Control as it is and not contextualizing it to the needs of Zambia. The last element of shared motivation, which focuses on shared commitment, essentially what brings, or the internal driver that brings people together to collaborate. We find that there's general acknowledgement of the tobacco control multi-sector action, of the need to collaborate, of the need for multi-sector action when it comes to addressing tobacco in the country. But shared commitment is also affected by, for instance, the lack of political will, which we see from the limited allocation of funds to tobacco control. So most of the activities in the tobacco control policy process were funded by international partners, and there's little to no government commitment of resources to tobacco control in Zambia. Here are some quotes from the participants. I'll read the first quote from a Ministry of Health official. Senior people are invited, but in most cases, junior officers are the ones that attend. If such a person has no influence, they can't bring any changes in their respective sectors. And referring to the issue of sector representatives' lack of authority, and which affects the legitimacy of the policy process there. We move to the third and last sub-study. The main objective of this sub-study was to unpack and describe factors that shape the capacity for joint action in the implementation of the national alcohol policy. So if you remember in the framework, the capacity for joint action was a third collaborative dynamics, which essentially refers to the capacity that is born as people interact in the policy process. And I specifically apply this dynamic to the national alcohol policy because it is more advanced in the policy process. And so this sub-study, I conducted 25 key informant interviews. I used both purposive and snowball sampling, and then I used deductive and inductive thematic analysis. On the right-hand side, you can see the paper that was published, that is paper 4, Inertia and Anticipated Bottlenecks, Exploring Stakeholder Perspectives on the Implementation Determinants of the National Alcohol Policy, 5 years post-enactment. At the time I was defending my thesis, I had received comments on this paper, and I already submitted those revisions, and I'm waiting for publication as of today. So what were some of the dynamics that shaped the capacity for joint action in implementation of the alcohol policy? We found that there was a general recognition of the alcohol policy as a basis for action amongst the different stakeholders, which is that generally those working in alcohol control in the country were of the view that it is better, at least we have a policy that provides a framework for action, but it can guide all of us at work on alcohol control. And then they felt that having a policy in itself is better than not having one. Of course, they acknowledge some of the limitations in the content and the design of the alcohol policy itself. The other factor that shaped the capacity for joint action was the restructuring of the Alcohol Policy Coordination Committee there. According to the participants, really, the Coordination Committee was initially headed by the Ministry of Health, which had also been the institution responsible for developing the alcohol policy. But once the alcohol policy had passed implementation, the Coordination Committee had to be restructured because Ministry of Health did not really have the capacity to implement the policy. And so Ministry of Health, and so the policy was then assigned, or rather transferred, to the Ministry of Local Government and Rural Development, who are the custodians of the Liquor Licensing Act, but more so they have different structures that oversee the licensing, sale, and distribution of liquors in the different communities. And so Ministry of Health at implementation stage, or in the new restructured committee, is the secretariat, whilst the Ministry of Local Government is the chair for the implementation coordination committee of the alcohol policy. According to the participants, this was considered a positive because what it meant is that, local government, which has a structure, could easily implement the alcohol policy. Another important activity in the restructuring of the coordination committee was the reducing of the coordination committee to a core group of members that includes key ministries and key civil society organizations. So what that has done is to expedite decision-making, which had been a problem prior to the restructuring of this committee. And lastly, the other dynamic that shapes the capacity for joint action is the limited resources and coordination challenges. We note coordination challenges between, for instance, the Ministry of Home Affairs, the State Police, and the Council Police around who should implement aspects of liquor licensing, or who should enforce, aspects of the law when it comes to harmful alcohol consumption. And there are general resource challenges, including human resource challenges, finance challenges, all those affecting the capacity for joint action when it comes to alcohol control there. I'll read one of the quotes. I'll read the second quote there from the civil society organization representative. If council workers responsible for patrolling and confiscating illegal alcohol aren't paid their salaries, it poses a great challenge. Government should establish a sustainable method for paying these workers, essentially referring to the resource challenges affecting capacity for joint action there. So in conclusion, really, what I found from my work is that there are huge differences in smoking and binge drinking, particularly among men and women. And some of these findings call for reshaping, really, and adopting collaborative control strategies that target at-risk groups. And the at-risk groups include men, older adults, the less educated, particularly when it comes to smoking, whilst urban residents when it comes to excessive drinking. We note as well that the collaborative dynamics in the tobacco control policy process are fraught with many challenges that pose a threat to critical outcomes of collaboration. And then overcoming coordination and resource challenges among implementing agencies can enhance collaborative implementation of the alcohol policy in Zambia. Some recommendations specifically when it comes to rolling the wheels and enhancing collaboration. Enhancing principled engagement in tobacco control. We'll need to align the legal and socioeconomic environment to support particularly tobacco control supply side measures. We as well need to encourage active and meaningful participation from the sector representatives, as well as improving communication amongst stakeholders. Building shared motivation in tobacco control, how do we foster trust? It will be essential to adopt strategies that create opportunities for open discourse and respectful interactions among stakeholders. And this will help to reduce tensions, to reduce fears, as well as suspicions. Improving mutual understanding, we need to create, to promote a cultural shift towards collaborative information sharing around tobacco control, as well as to enhance legitimacy and commitment. The policy stakeholders will need to have, the power and authority to influence appropriate tobacco control actions in their respective sectors. Strengthening the capacity for joint action in alcohol control will require that we challenge cultural norms, but as well as a country commit resources to alcohol control and improve coordination amongst the key sectors that are implementing the alcohol policy. That's the end of my presentation, and thank you all for your time and attention. I acknowledge the following institutions and my supervisory team for the support during the PhD process. Thank you.
Thank you very much. Should I remove this? I think you can adjust it.
Yeah, you can.
Sorry, we are swapping position. You can just come sit.
Yeah.
You're on mute, Dr. Nyasulu.
Oh, sorry for that. Thank you so much, Dr. Surungu, for such a comprehensive and very interesting presentation that you've just given us on what is happening in Zambia around alcohol and tobacco. Now, let me see if I can take some questions. Any questions or comments? Okay. Do I see a hand raised?
Yes,
yeah, Prof. English.
Yes, thank you. Thank you, Adam, for that really great presentation, and congratulations on the publications and also on receiving your PhD a few weeks ago, and for sharing that with us. I wondered how this was received, how your findings were received by the stakeholders, particularly the policymakers, and what the appetite is to engage with your recommendations. Thank you.
Over to you, Adam. You can respond and then we'll go to the next question.
I think you can mute now. Yeah. Hello?
Just wait. Yeah. Yeah. Yeah, you can go ahead and respond.
Okay, thank you. I think it's echoing, Dr. Nyasulu, you can mute. Okay. Thank you, Prof. Renee, for that question. Yeah. So I've had the opportunity to disseminate my results, but I'm still engaging the National Alcohol Policy Coordination Committee, and also the the Tobacco Control Policy Development Committee. Since the graduation is recent, I haven't had the opportunity to engage. But last year in December, we had, as part of two NIH funded projects, constituted a symposium on different stakeholders working on non-communicable disease risk factor control. And I had the opportunity there to introduce to share my work. Generally, the reception was very positive, and they recommended that I engage the Alcohol Policy Implementation Coordination Committee, and also just become, possibly because of my work, get to be part of the committee itself. So I think that's what I can say for now, Prof. Renee. Yeah, can you hear me?
Yeah, and I think it's really great that
Okay, so due to technology, I think rather the laptop, because there's a lot of echoing if we use different laptops. Okay. So thanks, Prof. English. Are you happy with the response?
Yes, I think that from what you're saying in terms of being invited onto the committee, the kind of work that you have done, the health systems and policy research and lens, and then being invited onto the committee is yet another example of how research can influence policy, but also how research can possibly change policy. So yeah, this is a very good example of that, the impact of your research, and hopefully the ongoing potential impact of your research. Thank you.
Okay, thank you. Any other questions, comments? So, Adam, if I may ask you. Okay, so you highlighted the fact that the alcohol policy actually is being implemented.
Yes.
But there are a lot of challenges in the implementation in terms of, like the age regulation, the regulation of who to sell alcohol and where. You are talking of, you highlighted the fact that there's a lot of compromise around that. Maybe if you can talk around that, because it's quite a challenge if a policy which is already under implementation is having so much challenges, and then there's another tobacco policy which is being pushed towards under implementation, then definitely there could be similar challenges in implementing it after everything has been concluded. So talk about it too. What is happening around law enforcement in terms of compromise in implementing like alcohol policy in Zambia?
Yeah. Yeah, thank you, Dr. Nyasulu, for that question. Well, part of my work really, as I mentioned in the framework, was understanding the system's context. And a lot of things that I uncover, which is the political, legal, socioeconomic, and cultural dynamics that shape, the policy process and collaboration in implementation. Alcohol in itself generally is, for instance, the framing around alcohol being, or the alcohol industry being a major economic player in society. I think in a country like Zambia, what you find is that there's a lot of illicit alcohol production, which is unregulated. But the policy in itself is hampered by the lack of the law that, for instance, regulates production and distribution of illicit alcohol. But there are also other cultural dynamics that I think manifest even in the collaborative arena. Like for instance, um, um, uh, in our culture, I think, which also relates to here, alcohol is not so much considered as a problem, you know, and people are easily engaging in alcohol business in the country like Zambia, and that also is a major issue that I think that the alcohol policy in itself did not factor into. Um, you know, um, yeah, the issue of early drinking as well, early initiation when it comes to drinking, are some of those, those are some of also the other dynamics that feed into the normalization of drinking. And I think that affects, implementation of the alcohol policy and generally how the stakeholders get to perceive action to control tobacco in the country.
Okay.
So
it's quite interesting, quite interesting.
yeah.
I see there's no hand here. My other question is, throughout your presentation around alcohol and tobacco,
Yeah.
I observed, a strong power imbalance, of the people who are pro alcohol and tobacco being financially up and, nullifying even the scientific evidence about the harmful effects of tobacco and alcohol.
Yes.
Which is quite concerning, because I could see that the CSO, the advocates, the activists, they've got no resources and power, because they were always talking of, we don't have money for meetings, etc. What the people there in the board, they are talking, undermining science, undermining their advocacy. That is quite a huge concern, What would you comment around that?
Yeah, I think it's true. The issue of contestation when it comes to how big a problem tobacco and alcohol are in Zambia is quite real. I talk about it quite a lot in my thesis. For instance, we haven't, like for instance, we've had like the demographic health survey, which collects data on other things and the health issues. There are a few questions there on tobacco and alcohol, but not exhaustive. Okay. But like for instance, in Zambia, we've had the only nationally representative survey we've had on the problem of tobacco and alcohol that collects many variables was the recent STEP survey of 2017. And it's also not regularly undertaken. It was sponsored by the World Health Organization, but we don't know when the next one will come, because the previous one was in 2008, but it was only done on Lusaka. You get me? So that is affecting the advocates in terms of the tools to, yeah.
But anyway, but I think there's a lot of global evidence, around this, and I don't think it is worth it for them to be, nullifying, like, undermining such, evidence, scientific evidence that is there in Zambia, in Africa, and across the globe. So it's quite concerning, but I can see that we can always bite one step at a time.
True.
Slowly, never to give up, keep the advocacy and keep going, fighting for, for reduction in the harm that is caused by tobacco and alcohol influencing policy.
Absolutely.
Yeah. Any other comments, questions? Okay. If we don't have any other comments or questions, then I think you would go to the closure of the webinar. So I would like to say thank you, everyone, for your participation, for your time. I hope you have had the benefit of learning more on what is happening in Zambia, and the advocacy challenges that are happening right there, and the fact that there is need for more evidence, to carry on with the advocacy. And Adam, thank you so much for coming to our division today, and even to take this opportunity to share your PhD findings with us through the webinar. So thank you, everyone. Bye-bye.
Thank you, Prof, and thank you, everybody, for your time.
Thank you.
Thank you.
Thanks, everyone.